Today we will talk about a very sensitive topic, which is progesterone elevation on trigger day. The fear of progesterone elevation has changed the scenario, and almost everybody, has started thinking about freeze all and transfer in the subsequent cycle. Progesterone elevation itself is a controversial subject. There are very much controversial conclusions available when you review the literature. Some studies believe in fixed cutoff of 1.5 nanogram. Some studies that it is an extreme high progesterone which is responsible. Milder elevation doesn't make any difference. So there are different conclusions. So we have to think logically, we have to summarize all the studies, and after reading and studying all the research paper, I have concluded that there cannot be a single cutoff of progesterone level. This all depends on whether you are using recombinant FSH, whether you are using HMG, whether you are using combination of the gonadotropin. It also depends on how many eggs have been retrieved. It also should also depend on the protocol, whether it is a long protocol, whether it is an antagonist protocol, and whether it is a flare protocol. So those who are believing in fresh transfer and those who do not want to increase the embryology load on the lab for the unnecessary freezing and thawing, they can keep little lower threshold and they can get equal results. So the luteinization means serum progesterone when it is more than 2 nanogram. It is called luteinization, premature luteinization of the follicle. The subtle rise beyond threshold in agonist is up to 35%, and in antagonist protocol it is little higher, up to 38%. The progesterone elevation is more common when recombinant FSH is used, where there is hyper response, and when there is ovarian hyperstimulation syndrome. So in such patient, if you keep the cutoff low, you are overdoing. You are unnecessarily avoiding, you are unnecessarily not transferring the embryos which could have given you a good results. The results are compromised with recombinant FSH when the progesterone on trigger day is more than 1.26 nanogram. When the HMG exclusively is used, this cutoff of progesterone elevation raises to 2.2. Such a huge difference between recombinant FSH and HMG. So when you are using HMG, you are literally worry free for the progesterone elevation. And when there are few centers, the most of the centers, when they are using combined recombinant FSH for initial phase of the cycle and HMG in the later half of the cycle, there they should keep the cutoff 1.5 nanogram. Now, if we have to think cutoff based on a response, then cutoff is low when less number of eggs are retrieved. For example, less than 5 eggs are retrieved, the cutoff is 1.6 nanogram. If 6 to 19 eggs are retrieved, then cutoff should be 2.24. And if more than 20 eggs are retrieved, cutoff can be kept at 2.5 nanogram. Now, if we have to keep protocols in mind, then for long protocol, cutoff should be lowest, that is 1.2 nanogram. Whereas if we are using antagonist protocol, cutoff can be kept at 1.5. And if we are using flare protocol, the cutoff again can be kept at 2. So we have to understand the response, protocol, as well as which type of the gonadotropin we have used before arbitrarily deciding the cutoff and taking a decision whether to transfer fresh or freeze all embryos. A day 5 embryo transfer lead to similar clinical pregnancy rate regardless of whether progesterone level was elevated or normal. This was a conclusion of one study, whereas other study says if the progesterone is elevated, irrespective of day of transfer, number of the embryos, quality of the embryos, the results are poor. The more recent data confirm the recent publication demonstrating a negative impact of elevated serum P level on the day of SCG administration with live birth. In addition, this data also demonstrated that this negative impact on live birth occurred in both cleavage as well as the blastocyst stage embryo transfer, poor, fair, and good embryos, and across the spectrum of ovarian response and woman's age. This result is obviously, as we discussed couple of seconds back, contrary to the prior report from Pepe Collier, who demonstrated a negative effect in cleavage stage but not in blastocyst transfer. So, if you want to avoid a progesterone elevation, what is the simplest solution? The simplest solution is you should avoid hyperstimulation, use minimum dose of gonadotropin. Your protocol should be mild stimulation. The protocol should be LH based stimulation protocol. The trigger should be early in high responder, and if you can manage, ideally you should freeze all embryos and transfer in the subsequent cycle. So this was a very practically important points which you must remember for progesterone elevation on the day of trigger. Now there are few centers who uses agonist depot in stimulation. There is one protocol called ultra long protocol in which the decapeptyl depot 3.75 milligram subcutaneous is given on day 1 or 2 if the follicle size was less than 6 millimeter. After giving this injection, confirm the down regulation after 28 days. We have described a criteria of confirming down regulation in the earlier talk, so I did not repeat. So after confirming the down regulation, start stimulation. No further gonadotropin agonist will be required as the down regulation is maintained for 8 weeks after decapeptyl, which is very positive effect of decapeptyl, and it gives a longer down regulation. They found that endometrium was very good due to possibly break of monotony of endometrial response to steroid. The more gonadotropins were required, but the good quality embryos were observed and significantly high live birth rate was observed. So they suggested that ultra long protocol is ideal protocol for young normogonadotropic woman. In standard long protocol, if we use if we want to use a depot injection, then normally most of the center practice they inject one third of the ampule of lupride depot in the mid luteal phase, and they confirm down regulation after 14 days before starting the stimulation. Now we will discuss a microdose SCG protocol. In this protocol, they use a smaller dose of SCG and replaces the gonadotropin in the later half of the cycle once this follicle acquires LH receptor. The advantage are economy and it maintains a luteal phase in a better possible way. So in this protocol, the starting of the stimulation is a standard way of agonist or antagonist, whatever you prefer. Injection SCG 200 international unit per day subcutaneously given when more than 6 follicle more than 12 millimeter and E2 more than 600 picogram as a sole stimulation drug. Means once there is criteria observed, more than 6 follicle, more than 12 millimeter and E2 more than 600 picogram, then purely SCG can pull further the rest of the cycle and stimulate those follicles very well. The discontinuation of the FSH or HMG in last days of control ovarian stimulation prevents recruitment of the new follicle which can be responsible for ovarian hyperstimulation syndrome, which is very important. In a long agonist, daily 20 to 30 units of SCG, and in antagonist protocol 10 to 20 units of SCG should be a part of stimulation. We will discuss a sweet point for LH activity in some other talk, which says that in all spectrum of the patients, all protocols, the LH activity should be must from the beginning of the stimulation. But recombinant LH, of course, is ideal, but the recombinant LH is costly. So, economical version, as suggested by the Abulgar, in long agonist protocol, 20 to 30 units, in antagonist protocol, 10 to 20 units of SCG should be a part of stimulation. The LH activity of the SCG, it is not capable of stimulating excessive P secretion, so one should not worry. Only large doses, not a smaller doses like 100 unit or 200 unit of SCG. The doses of 5,000, 10,000 international unit only can trigger luteinization. In fact, small dose helps in augmenting a luteal support. Now the question comes how to prepare such a small dose of SCG. Such a small dose of SCG is not available in India. So what we do, the Bharat serum UCOG is liquefied, it available liquefied form 2000 international unit per ml in liquefied state only. So if we take the 100 unit insulin syringe, then 1 unit of insulin is equal to 20 units. So whatever dose you want to give, whether you want to give 20 units, 30 units, 200 units, it can be easily administered through this insulin syringe. If you are not comfortable to inject a smaller dose, then this SCG can be further diluted with the normal saline and can be kept for next 3 to 4 days in refrigerator after uses. So which makes the protocol economically viable, still without the compromise of the result. Now, what are the different modifications suggested for the poor responder? The most important and most efficient modification is addition of growth hormone. It is to be added 8 units daily from stimulation day 7 till ovum pickup. This is a one way, or 4 to 12 units from stimulation day 1. This is another way, or 0.5 units from the down regulation in long protocol. So these are the three doses schedule of administering growth hormone which is easily available in India. The agonist enhance steroid genesis and oocyte maturation by local production of insulin-like growth factor. The growth hormone from luteal phase not helpful in mini flare protocol. It is only for long agonist protocol. The another modification which can be useful is adding dexamethasone. Sometimes I say funnily dexamethasone is poor man's growth hormone. If it is given in the dose of 1 milligram daily along with the stimulation, it stimulates the growth hormone and IGF-1. Another addition is addition of DHEA. DHEA is a controversial molecule. There are few patients are very happy with DHEA. It improves enteral follicle count, AMH level, response to the stimulation, whereas in many of the patients it is ineffective. It reduces the granulosa cell apoptosis and enhance a proliferation. It increases the androgen concentration around the resting follicle, which may increase the ovarian response to a stimulation. But it is to be given at least 3 months prior to a scheduled stimulation. There is a role of L-arginine, but doses used is very high, 16 grams per day. There are few centers who keep increasing the gonadotropin in case of poor responder. But now it is clearly understood that increasing the dose beyond 450 doesn't make sense. It increases the oocyte yield, but those oocytes are resistant oocytes coming from the resistant follicle and they are not going to give the pregnancy. So ultimately you are back to square one only. So there is no point in increasing the dose beyond 450. international unit of gonadotropin. Now, the next time we will talk further on diminished ovarian reserve and other things. Thank you.